about a 15-year-old female patient. So she has MDD, anxiety, OCD, trichotillomania, and ADHD. So she did a 3.5-month inpatient OCD treatment center. This is her regimen, so sertraline 250, Abilify 7, Wellbutrin 150 ER, metformin 1,000 milligrams. So decent regimen for a 15-year-old patient. So patient says that OCD is controlled, but there's still a lot of hair pulling, feeling sad all the time, passive SI, fatigued, changed the Abilify. So, and then these are some of the med trials, hydroxyzine, NAC, Vyvanse, and these were the labs. So, yeah, tell me more about this patient, anything else we should know, and what your current treatment plans and processes.
Yeah, sorry, I'm outside. Hopefully the sound quality's not too bad. But yeah, this patient came in with her father. It's clear that she's very depressed, saying passive suicidal ideation. She does say her OCD symptoms have gotten better. She described them as hyper-responsibility OCD, and she was put on Abilify during her inpatient treatment. She was describing, also saying like she had some symptoms of possible auditory hallucinations, like she would hear her name being called. She wasn't clear if this resolved with the addition of Abilify, but basically she said like all of the obsessions that she would have resolved on the 250 sertraline and 7 of Abilify. But while she was sitting in the office, she just was like exhausted, yawning, falling asleep. And so it did cross my mind, like maybe increasing the Wellbutrin. She does have ADHD as well. What I did was I had them check the labs. They said it was unremarkable. So then we decreased to 5 milligrams of Abilify, and I haven't seen her since. But so I was just kind of curious, like, because her depression is still so severe, she's so tired. I wanted to address that, but I don't want to destabilize her OCD progress. I was just kind of, I don't know. And next steps, I was thinking like Lovita also put in the comments, like maybe switching to Prozac to be more stimulating would be good, which I agree. I think that would be great, probably a good choice. So I'd be curious kind of about like that cross taper schedule, what that would look like, and if amitriptyline would maybe be an adjunct or something to just switch to. I'd be curious about those things.
Gotcha. So let's walk through everything that you said one by one. So the first thing you mentioned was the fatigue and the depression. So let me ask you, where do you think that fatigue is coming from?
Yeah, I guess now I'm thinking about it, Abilify can be more stimulating sometimes. So I was thinking maybe that high dose of sertraline could be causing some of that. Yeah, I suppose that's where it would be with her med regimen. And I was curious about ruling out thyroid conditions and other things. She does say she also has irregular heavy periods, so there was some, I was thinking maybe PCOS. Anyways, what would the WAD be for that? I'm very new to practice, so I do have a lot of anxiety about, starting the right things and going through those protocols.
Of course, no worries. So it's a complex patient, so let's work through all the different components together. So immediately starting out, we see that this patient has numerous comorbid diagnoses. They've been inpatient OCD treatment center. So let's just walk through it all. So this inpatient OCD treatment center, my thought would be, okay, what did they do here exactly? I know that Levita mentioned the ERP. So did they do any kind of ERP? Is she getting any kind of ERP right now?
Not right now, it sounds like, but I would imagine that happened inpatient. I didn't ask though, so I should.
Got you. Okay, no worries. And then the next thing we have is this fatigue and the depression. And the reason I say that is because fatigue and sleep worsens everything else. So I'm a big believer in getting sleep optimized, because if the sleep is optimized, then everything else gets better. Impulse control gets better. Their thought processes get better. They feel more motivated during the day. So everything gets better with sleep. So with this fatigue, is it from the medication that's causing her to feel fatigued, or is this that she's not sleeping well? Because those would be two separate problems. The sertraline, do we know what time of day she's taking it?
Just taking it in the morning.
In the morning. Okay.
Yeah, in the morning.
So
She didn't say she had. Oh, sorry. Go ahead.
No, you go ahead.
She didn't have any problems with sleep, as far as I remember.
Okay, so she's sleeping 7 to 9 hours per night. She's able to fall asleep, stay asleep, all of that. Okay, so if we rule that out, then looking at the sertraline, so it's possible that sertraline could be causing some sedation. It's supposed to be slightly activating, but it's possible to be contributing to it. So perhaps switching it at nighttime could make a difference for her, or like splitting up the dose. For example, you could do like 150 at night or 100 during the daytime. That way it's more spread out rather than just all at once. So those could be it. So basically, because when I think about cross tapering, so cross tapering can be helpful, but I think that's more valuable if the patient has had not much benefit from it. But if she's saying that her OCD symptoms are controlled, but the patient's having hair pulling, so it's like we've gained a lot of ground already with the OCD. So I'd be hesitant to get rid of something that we know has already given her a lot of ground. So that's where I tend to favor more the augmentation strategy. So if, let's say she says that I've had no benefit from sertraline, I'd be like, okay, like we should definitely switch. There's no point in continuing. But since she's telling us that she says the OCD symptoms are controlled, which is a big admission for her considering she stayed here for 3.5 months. So that tells us that, okay, it's probably doing something. So that makes me less wanting to switch over to something new and more wanting to augment. So with augmentation, I know you mentioned amitriptyline. Clomipramine is usually the go-to for OCD. That's the one that tends to have the best level of evidence for OCD treatment, and you can definitely augment.
I think I meant to say that.
No worries. So you can definitely augment with clomipramine. Like start at 25 milligrams, go up to 100, 150. That's it's a very reasonable thing to do, and so just be mindful of serotonin syndrome. So she's already on a higher dose of sertraline, but in OCD treatment, it's an acceptable thing to have high serotonergic medication just because of this reason. Like it's just a difficult thing to treat. And for 15-year-olds, their metabolism tends to be faster than adults. So that's something to be, she might be metabolizing it a little bit faster too. So that's just something to keep in mind. But now this fatigue that we, let's start with the hair pulling here because that's next on the list. So when I hear about this hair pulling, so that tells us that there's some level of, do we know why the hair pulling is existing? Is it like a remnant of the OCD symptom? Is it a new thing that's popped up?
It's been there. I assumed it was with the OCD symptoms. But she said that hasn't really improved since her time inpatient.
Okay.
Whereas the other things did.
Got you. So, and then the other advantage of augmenting with clomipramine is that it's also an antidepressant. So that may help her with the depression that she's having, the passive SI. And it's dosed at night typically too. So, if she's able to get better sleep, then that might help her fatigue. But the con of that is that it could make her a little bit more fatigued as well. The downside, the Wellbutrin you could increase. The downside of that is that if she gets too stimulated, it may make the OCD worse during the day. So that's the downside of that. Because think about OCD, it's too much activity in the frontal lobe. Like that frontal circuit is just too active, so she's just hyper stuck on that thought. And so ADHD or the stimulating medication can actually stimulate it further. So just something to keep in mind. I know you mentioned Abilify, you reduced. Abilify can go either way. It tends to be more of a stimulating antipsychotic, but it can be fatiguing. So so that's another thought that I have on that. When I hear these past med trials, so hydroxyzine caused insomnia. So just to clarify, did you mean sedation?
So no, she says she has a lot of paradoxical reactions to these medications. Like the NAC actually worsened her hair pulling, and the hydroxyzine she couldn't sleep, is what she said.
Okay, so that was my next question too regarding the NAC. So is it a clear correlation that it got worse, or it's more like she already had hair pulling and she took it and she maybe thinks it got worse, but then, when she got off of it, it's not like the hair pulling went away either.
Right. I should dive deeper into that timeline because, it sounded pretty strange to me. But I would imagine it was probably just present and maybe she had some other thing exacerbate it while she trialed NAC. So, maybe worth looking at that again.
That's my suspicion as well, because correlation doesn't mean causation. And then one thing we want to do is, so you see, like, now if we see that this doesn't work, so now we think that, okay, we shouldn't do this anymore, when in reality it may not have been an adequate trial. There could have been something else that was going on, and so now we've thrown out a perfectly good option because of just like something that the patient was miseducated on.
Yeah, right.
Yeah, so that's that. Then when I look at these labs as well, so I see we selected BMP iron. So you mentioned that she has heavy periods, so the fatigue could be from, for example, the heavy periods, like she could be iron deficient. So do we know if ferritin was checked and total iron binding capacity, or was it just serum iron?
I'm good with just serum iron.
Yeah, so think about, so ferritin is definitely the most valuable to check with the iron deficiency. Think about ferritin as money that's stored in the bank, and then the serum iron is like the cash you have in your wallet. So you may appear that, okay, iron is normal because the cash in your wallet is normal, but that's because you withdrew it all from the storage from your bank. So really you're deficient.
Okay. Yeah, that makes sense. Okay.
Yeah.
Good to know.
Yeah, and so that's why I would make sure to check ferritin as well, especially if
ferritin. Okay.
Yes. I would definitely check the labs yourself, because, for example, you may be told that they're within normal limits, but she could be like on the cusp, for example, for anemia.
Yeah, right. I want them to send those over. I'll ask again.
And then the vitamin D3, for example, she could be at like 30 or 31, where technically it's normal, but I think optimal functioning is 50.
Okay. Right.
Yeah. So those are some of my thoughts regarding this case.
Yeah.
Checking the labs, making sure that the supplements were good, especially the NAC, considering clomipramine augmentation, and then, if those things are addressed, then considering Wellbutrin increase for the fatigue.
Okay, yeah, that's so helpful. Thank you. I do have one more question. With the clomipramine as augmentation, right now the Abilify is kind of there for augmentation. Would you recommend keeping the Abilify or switching it out for clomipramine?
Do you think the Abilify did anything?
So I just met her, so it's very hard for me to tell, and she didn't have a clear idea.
Okay.
She said she got more tired when it was increased to 7. That's why I went down to 5, but it's so hard I just need to get a better timeline with her. She's a little bit, she doesn't really know like when her symptoms got worse or better in conjunction with med changes. So that's why it's been a little difficult to tell, but.
Yeah, of course. She's a 15-year-old girl.
Right.
So I think there's only so much to expect there. But yeah, so I think that's the thing with every kind of intervention and medication. We have to assess the risks and the benefits and whether it's doing something. So my thought would be, okay, if the Abilify you feel like has helped her quite a bit, then it makes sense to leave. But if it hasn't done anything, and in fact it's made her tired, then it probably makes sense to choose something else.
Okay. Yeah. Thank you so much. It helps me think through other cases too, like the process you're going through. So yeah. That's super helpful.
Of course. Yeah. Anything else on that?
Not really. No, I think that really gives me guided direction to go.
Yeah. Awesome.
Oh, sorry guys. I'm in the way.
Okay. So then your next question was...
That's good that you mentioned... Oh, I'm sorry. I just wanted to tell you that's really good that you mentioned splitting the dose. Because I've had people say, why the heck would you ever split a dose? I'm telling you, it does help.
No, it does help, for sure.
Just to let you know, that's a great thought, too.
Yeah.
The circularly. So.
Yeah. So, because then now that way, by splitting the dose, you can get her additional benefit from her current regimen. You can optimize it without changing anything.
Right. Yeah. That makes sense.
Yeah.
Okay.
Okay, so then your next question was...
Yeah, I have another question.
If a patient's taking trazodone to help with insomnia, having trouble with sleep maintenance. Is low-dose doxepin a better choice? Curious if taking trazodone above 50, like 100, 150 is reasonable. Okay, so this patient, tell me more. What's going on here?
Yeah, so this patient is on other medications for depression, like the highest dose of venlafaxine, and then I think 300 of Wellbutrin, and then 150 of trazodone for sleep. So some like stimulating medications with this, but she's basically saying she falls asleep just fine, but then will wake up multiple times throughout the night. And I remember, I think just hearing from you and some of the classroom things like doxepin's better for maintenance.
Mm-hmm.
So I did want to think about switching her from trazodone to doxepin because she has other antidepressants on board, but I wasn't sure exactly, like when I was looking it up online, it says trazodone should be tapered if it's at 150, but then I just hadn't really seen that done, so I didn't know if I could just go straight to recommending doxepin instead, or since she's on an antidepressant dose, if I should lower it, see how she does, and then switch or cross taper. That was, where I was
Got
at.
you. Okay, so let's work through that then. So the first thing we see is that she's on venlafaxine and Effexor, so two both very stimulating meds. Is she taking them at night?
She was thinking that she was a little confused too about what her regimen, but I think she's taking even though she's taking every day. So I just clarified to make sure she was taking them in the morning. So at the next appointment, I'll double check with her. But
okay.
So she was a little confused on that, I think. But at the end of the appointment, she said it was in the morning. So
okay, gotcha. I would just clarify that. But the reason I say that is because we always want to make sure that we can address, rather than adding on more meds, we want to try to optimize what her current thing is. So, if she's on two stimulating meds, the question would be, okay, does she need to be on these two stimulating meds, right? Could venlafaxine be dropped down? Could Effexor be dropped, or Wellbutrin be dropped down? Could one be swapped for another? So, because those could definitely be contributing to sleep problems, sleep maintenance problems for sure. So that would be just like the initial thought I would have. See if she's open to that. See if she's worsened, if she's noticed worsened sleep with the increase of the stimulating medication. So, because then that would be the first thought. How old is the patient?
She's about 40.
40-ish, okay. Got you. And then so when you say sleep maintenance problems, what exactly does that mean?
She's saying she's going to bed, staying asleep for about 2 hours, and then wakes up around 1 a.m., 3 a.m., 4:30 a.m. About 2 or 3 awakenings in the middle of the night, and then going back to sleep within half an hour.
Okay, do we know...
So just for brief periods.
Do we know when it started?
I don't know. Yeah, I'm not sure. She does also smoke marijuana at night to try to help with sleep on top of all this.
Right.
But no, I'm not exactly sure when her problems started with sleep, so I should definitely clarify that.
Got you. Yeah. So I think that timeline can be helpful as well.
Yeah.
So she wakes up. Does she smoke nicotine?
No, not nicotine.
Okay, got you. So and then 150 is not helping her stay asleep either?
Apparently not.
No. Okay. Yeah, so in that case, something to help with maintenance could be helpful. So a couple thoughts. Doxepin could be helpful. Supplement-wise, magnesium glycinate is helpful as well for that too. If you want something even antidepressant-wise, mirtazapine could be helpful for her. So that could be a consideration. There's XR serotonin or XR melatonin, which could be helpful. There's also XR Seroquel, which could help with some of the depression side as well, if that's not fully controlled.
Yeah, she also is having some irritability during the day. So I was wondering maybe Seroquel. Do you feel that would potentially address sleep and daytime irritability?
Yeah, it can. Obviously, Seroquel has the con of the weight gain, so it has to be like a benefit versus risk decision that you make with the patient. But my initial thought is, investigating why the sleep maintenance is an issue, and I suspect it's the medication, the double medication related.
Yeah. She also wasn't very adherent to the venlafaxine. She's saying some days she's not taking it, which I know with the short half-life, so withdrawal could be potentially causing some of these problems.
Absolutely.
So explore that with her.
Absolutely,
Thank you.
yeah, ruling out, but yeah, you can stop it without much issue, because 150, like, I still consider that a sleep dose. Once it gets above 200, that's when I
Okay.
start thinking the shift is more towards antidepressant doses. But back in the day,
About 200. Okay.
people used to be on like 400, 500 of trazodone. So
Wow. Yeah.
nowadays we don't really do that.
Okay. Yeah. No, that's super helpful. I don't think there was anything really else on that case that was too pressing, but yeah. Thank you so much.
Of course, yeah. Okay, so Richard asks guidance for coding ACEs, sexual assault, and other Z codes. Some of these, like the abuse, includes the verbiage confirmed. Presume this is via review of documentation or physical assessment, but private practice, we don't have access to kind of evidence. Should we still include the code? Yeah, tell me more about this question. What led you to ask this? Was there a specific scenario?
Hello, good evening, first of all.
Good evening.
It's essentially quite a few patients that already come across my panel at some point or the other that had different kinds of qualifying criteria for Z codes. It doesn't always have to be ACEs, it could be real random things. Something that I see quite frequently is sexual assault, history of, and I'm just not sure what will be the correct way to diagnose it. It almost feels like that code is meant to be for the initial evaluation post sexual assault. I just think that I require a little bit more guidance just to make sure that I'm not doing the patient injustice.
Yeah, got it. Okay. So, at least from what I've seen in practice, pretty much nobody ever puts the Z codes. Because it's like Levita says, so it doesn't really add to the billable diagnosis. So, it's more work for you to have to dig through and put out, right? Because you have to document it, and it doesn't really add to any kind of increased revenue for the practice. So there's no advantages there. Of course, if you want to be a lot more thorough in your documentation, you certainly could. I'm just wondering what the advantage would be for you. The main advantage would be to convey to other providers that, okay, these are issues that are happening at a glance, but like those are also present in the note. For example, in the social history, you would say that there's X abuse or trauma or domestic or whatever the issue is that's going on. So I think it could be, my thoughts are that it's a nice thing if you really want to do it. I'm just wondering with the limited amount of time that you already have, back to back seeing patients, if it's worth investing that cognitive load trying to code that when it could be invested towards like patient treatment or education for yourself or something else.
Cool. I did listen to the podcast Lovetta spoke about, and maybe I misunderstood, but the guy said that coding a history of suicide or high risk for suicide, that specific code means that you can bill as a more complex follow-up instead of, for example, 99-14 and 99-15. Did I misunderstood?
Oh, okay. I see what you're saying. Yeah. So he's referring specifically for insurance level of billing, and so when you have to do that, for example, going from a 99214 to a 99215, you have to justify that it's a more complex case, and thus the insurance company should reimburse more. And so either you can do that by a time, so you spend, let's say, over 30 minutes with the patient, or through complexity. I don't know how exactly, if you have SI, how it translates it from 99214 to 99215. Like, I don't know the exact criteria off the top of my head, but essentially the idea is that the more complex the case, the more complex billing that you can do. But that could also be done with diagnosis too. So if you have, let's say, from 2 to 3 diagnoses, then you could do that. So I can double check that for you. Actually, I'm actually doing a podcast with him tomorrow, so I can ask him that specific question.
All right, cool.
Yeah. So I'm gonna write that down. So your question is for Z codes and 99215. Can adding in Z codes impact billing at all? Is that the exact question?
Yeah, precisely.
Okay. Perfect. I have written that down, and yeah, I'll ask him. I don't know.
Cool.
But in your case, right, if you're working at the VA, they're paying you X amount. I'm not sure what the value would be for you to do it.
Yeah, no, there's truly no value. I said in the best of practices, data codes included, but it doesn't matter at the end of the day because we get paid salary. Yeah.
Exactly. And then the other thing is that if you do start doing it, then now it's going to be expected of you. So so that would be do you want that?
No.
Exactly, yeah. Okay, so Natalia asks, she has a 66-year-old female. She has bipolar 1 manic episode 2 years ago. Patient was on Geodon, was taking 80 milligrams a day and also taking oxcarbazepine 150 twice a day. Started lamotrigine to address depressive symptoms. Geodon increased from 60 to 80, but it wasn't helpful. Some of the initial labs are normal, except the liver stuff, which was slightly elevated. So lamotrigine was increased to 50 twice a day. Geodon decreased to 60 daily. So that's funny. So she takes the lamotrigine twice a day, but she's wants to take the Geodon once a day. Doesn't like she's on so many medications, taking other meds for chronic conditions. Is it always necessary to have an antipsychotic and mood stabilizer on board? Wondering if one of the newer medications like Vraylar will be sufficient to replace your current regimen. Got you. So this is the question about, okay, so I'm sure this was probably the regimen that got her stable. And now the question is, okay, how do we make sure that she maintains stability? So this happened 2 years ago, so we do have some leverage to work with. It's not like this happened a couple months ago. What's the rationale for switching? So that's what I'm wondering right now. Maybe I missed that. So you're asking, is it always necessary to have an antipsychotic or mood stabilizer on board? No, not necessarily. Once someone's in maintenance phase for bipolar for, like, I like to do at least 6 months to a year-ish, then you can start tapering back and just making sure that they don't get into any kind of manic episode. Now, oxcarbazepine and lamotrigine are not really good mood stabilizers to prevent mania. Those are maybe more for mood maintenance, more for the depressive side, but for pure mania, the best mood stabilizers are Depakote and lithium. But then, I'm sure that there's probably other issues with that given her age. These ones are better just for mood stability in general. And I think you'll be better off stabilizing her mood with an antipsychotic rather than with any of these. Personally, I would think, okay, does she even need the oxcarbazepine? That would be my question. I just don't think it's that useful of a medication overall. And that's why it's always like third line for any type of treatment in the bipolar algorithms. It's usually a third line thing. It's not a first line thing by any means. So that would be my question. Regarding the Geodon, is there any reason to change it? That's what I'm wondering. Like, it seems like she's doing well. You're addressing the lamotrigine. You're increasing the lamotrigine to address the bipolar depressive symptoms. So it looks like you're asking if one of the newer medications like Vraylar will be sufficient to replace her current regimen. I see. Okay. So now you're wondering if one med can substitute the place of all three. So yes. So Vraylar has been shown to be efficacious in both bipolar mania as well as the depression side. So that can be really helpful. So that could help you clean up a lot of her regimen because it sounds like she's getting upset that doesn't like that she's on so many medications. So Vraylar could be helpful. Seroquel can also be helpful for that because it's got a lot of evidence for bipolar depression as well, and it's used in mania. I also like Seroquel because of the sleep benefit that it gives. So it helps people fall asleep, and that can be protective against mania because lack of sleep is a big trigger for it. With Seroquel, of course, the weight gain and things I would be worried about. But over here, you said that the lipid panel, the A1C, was all within normal limits. So you're starting off at a pretty good spot here. But then you've also said she's taking other meds for chronic conditions. So, I would just make sure that those chronic conditions are not like weight gain type of conditions. Abilify, that can also be helpful as well for a lot of the depression treatment. Geodon is not as effective to treat. It's definitely effective for the mania side, but not as much for the depressive side. So Abilify, Seroquel, olanzapine has some good depressive treatment evidence as well, and Vraylar. Those are all great options, and that could help you clean up her regimen. But also, if she is stable, then it's worth wondering, like, is it worth going through that if she's already pretty stable? So those would be my thoughts on this case. But now, if you do want to do that, for example, then what I would do is I would try to switch the one antipsychotic to the other. So I would do a cross taper. So as I'm coming off the Geodon, because she's older, so I wouldn't want to make any drastic changes with her. So as you slowly taper down the Geodon, like you could go from 60 to 20 to 40, or 60 to 40 to 20, that's where you can start titrating up Vraylar slowly. And then once she's on a good dose of Vraylar, then you could look at removing and assuming she's still maintaining her health and still having good mood, mental benefit, then you could look at tapering back oxcarbazepine. So that would be my next one, and then lamotrigine if you want to. So that could be a way to solidify the regimen. But I would also just make sure that you really want to do that, just because now she's older, and making changes can be hard for the elderly as well. Tally, are you here on the call right now? Okay, no worries. Yeah, but those are my thoughts hearing this. So anyone else have any input or anything else to add? Okay, awesome. Any other questions? Anything we didn't cover? Anything that just came up?
I have a very random question.
Yeah.
I had a patient's mom message me today, and currently she's on, I have her on Zyprexa, she's on 20 milligrams. She's 18, and she's on Prozac, 40 milligrams. Anyway, she went to Colorado, and the mom messaged me saying that her medications aren't working and that she researched online that altitude affects the metabolism of the medications. Is that, as far as I know, I've never heard of that in my life, but I wanted to make sure that that's not a thing. Maybe it is, I'm not sure. But she's only been in Colorado for 2 days or so, and she has PTSD, and I think a lot of her PTSD is why she hears these voices, and she recently had a very traumatic event happen where the voices have gotten worse. But anyways, I just thought I'd ask.
Okay, so let's walk through. So she's an 18-year-old female.
Yes.
And so she's in Colorado. How long is she there for?
She's only gonna be there for a week total, so it's a very short trip.
Oh,
but the mom
okay.
the mom had messaged me kind of panicking this morning. I guess she went to the ER in Colorado, and they gave her the Zyprexa Zydus, the dissolvable tablet, a 5 milligram one to get her through. So I guess that's another question I have too, is dosing wise. I mean, I'm scared to have her go above the 20 milligram.
And what is she on?
Again,
can you repeat it?
So she's on 20 milligrams of Zyprexa and then 40 milligrams of fluoxetine.
I see. Okay. So it sounds like what is she diagnosed with?
So she's diagnosed with PTSD, major depressive disorder with psychotic features, and anxiety.
Okay, got you. Okay. So, yeah, looking through this case, I mean, it sounds like the main thing when I think of altitude is now she has less oxygen in her blood. So because she has less oxygen in her blood, basically now the blood's going to be pumping harder, her heart's going to be pumping harder, and because of that could stimulate a panic type of response.
Mm-hmm.
And so, right, just the lack of oxygen type of thing. And so that was my first thought on why she's experiencing that.
Okay.
Yeah, so the second thought would be, okay, is there any substances involved? Like, is she, I mean, she's going to Colorado. I mean, that was the first legalization state, or second. So is there anything that's involved with either cannabis or alcohol or anything else, right?
Yeah, that's a good. I mean, I don't think she would, but again, who knows? Her
Yeah.
mom, her and her mom are very close. It's a very complicated situation that's happened to her. I mean, she's very compliant with her medications and everything like that. But she had this like stalker the last, I don't know, 4 years, and recently he went to their house, and so it re-triggered all of this stuff, and that's when these hallucinations, she was very stable and doing really, really well.
Yeah.
And then now all these hallucinations are back, and they were there before she went to Colorado, but anyway, sorry, I digress. But yes, okay, so I could tell her kind of potentially the panic could be related to altitude, but like dosing wise, the mom had messaged me this morning saying, I read online that you're actually supposed to increase dosages of medications before you go to places like this with higher altitude. And I was like, I have never heard of that in my life. But
I would actually think it'd be opposite, it'd be decreasing because of, I mean, now you have less blood flow, you have less oxygen, so your liver enzymes are less active, so they break it down or less. So therefore, you'd want to decrease it slightly. But I would think that would be over a while. Like, it wouldn't just be for like a week.
Mm-hmm.
You know, like if she's
it would take time. That was my
It would take time, yeah. And the question would be, how high is she going? Like, is she going to the mountain peaks, or is she just in Denver in a city?
Mm-hmm. Yeah, she's just in Denver.
Yeah.
In a city, yeah.
I suspect this is more of like a anxiety response. I mean, oftentimes, like you're saying, the mom and the patient are very codependent, so they probably feed off each other's anxieties.
Yes.
And that's probably much more of a thing. I'm not saying it's not a thing. I just wonder if it's playing much of a part right now. Like, if she's truly hypoxic.
It definitely could be. And with that age group, I know at that age, metabolism can be faster. And I mean, as far as dosing goes, because these hallucinations have kind of continued to be an issue. I mean, I think it is related to her PTSD and just everything that's happened.
Sure.
But the mom really questions, can we increase her dose? Can we increase her dose? I mean, what would you be comfortable with? I mean, the max is 20. I mean, would you be comfortable with increasing it? I try to do a lot of education with them, just with on PTSD. She is in therapy weekly, but
yeah, good question. So the FDA max is 20, but Zyprexa is dosed up to 30 milligrams at times. Sometimes a higher dose is needed, and so always remember that the FDA max is just based off of the studies that they did to prove that, okay, this medication works for X treatment. It's a guideline. And then, as you become experienced providers, that's when you can step away from the guidelines because you understand them, but you also know when to deviate from them. The most common example of this is in stimulants, when plenty of times patients need higher than the quote-unquote max. So similarly with Zyprexa, I've seen patients on 30 for treatment-resistant cases. In the prison system, for example, a patient with severe schizophrenia might be on 30 milligrams of Zyprexa and like 20 of Haldol. So it's a common thing if there's a lot of treatment resistance. Here, like, my thought would be, okay, are these true hallucinations that we're dealing with versus more just like intrusive thoughts related to PTSD? Sometimes patients get those confused. So that might benefit from an increase of the Prozac, which typically you go to higher doses for PTSD, like around 60 to 80. So that's something that I would wonder is this intrusive thoughts or is this hallucinations? And then my next thought would be, has she had benefit from Zyprexa so far? Because it only makes sense to increase if she's had somewhat of a linear relationship between dose increase and benefit. Because if she hasn't gotten benefit, let's say from going from 10 to 20, then going past 20 wouldn't make much sense.
Yeah, and it's been the best medication so far for her, so I could bump that up a little bit.
Okay. So
Sorry to interrupt you. So then do you, like in the cases of like treatment resistant, like for hallucinations, and do you sometimes use 2 antipsychotics?
I try not to. Sometimes in the prison system we do, but those are very severe cases. I doubt that she's at that level, but sometimes you do have to, yes.
Okay, yeah, because I just have had people come to me sometimes on 2 who aren't severe cases, but
Yeah.
but I was just curious what your thoughts were about that. But
Yeah, I mean, don't get me wrong. It's definitely not ideal. And then if you do stack 2 antipsychotics, you typically would stack one that binds more tightly to the receptor, and then one that binds more loosely. So, for example, like stacking risperidone and Haldol would probably give the patient severe TD and dystonias, because like risperidone is very potent, right? The dose is from 1 to 8 milligrams, so it's very potent. It binds tightly, whereas something like Seroquel, it binds a little more loosely. That's why, and it's not as not nearly as potent. So that's why the dosage ranges from 25 to like 1200. So so similarly, if you're combining 2 antipsychotics, you'd combine, like, let's say Zyprexa, and you might do chlorpromazine as the first gen, which might go from 50 to 200 or something. Does that make sense?
That makes sense. Yeah, that makes a lot of sense.
Yeah.
Oh, thank you.
Of course. Anything else? Any other cases or anything comes to mind?
Hey, sorry. I cleared my throat, apologies. I did a quick late review, and turns out that medications metabolized by the liver can in fact be affected by altitude sickness.
Mm-hmm.
So it inhibits the different CYPs and therefore allows for high concentration of the medication.
Right. Yeah, that makes sense. Less blood flow, less oxygen, less liver enzyme activity. So I think the time difference would be valuable here too. If she's there for a week, that might be different than if she's there for a while. Yeah, it can influence. I saw what you said. Can influence the serum concentration. So it downregulates them. So yeah, if you're super concerned, like what you'd want to do is decrease the dose. But it's saying specifically acute hypoxia. And it also says not all drugs are affected equally too. So yeah, I doubt in this case that's what's contributing to the patient's distress right now. But yeah, thank you for sharing that.
Yeah, that makes sense.
Yeah. Awesome. Anything else? Anything we didn't cover or talk about?
I just had a really quick question too. I kind of am thinking back to a decision I made today in clinic. I think I maybe jumped the gun on it, and I'm having a little thoughts maybe I shouldn't have started 2 meds at once. But I saw this is a 34-year-old female. Haven't seen her since November. She just ended up not feeling like she needed to come back. She also was seeing our in-house therapist, stopped seeing her, kind of for just said, I just didn't think that it was helpful. So she's been lost to follow up with both of us since last fall. She does have a known history of PTSD, suicidal ideations. She's got ADHD, autism spectrum disorder, major depression disorder, social phobia, insomnia, generalized anxiety disorder. So we did do a gene site on her when she saw the primary care doctor about a month ago. She basically has failed a whole laundry list of meds in the past. So she had the gene site on board when I saw her today. And Prestique was certainly in her green. So the symptoms that I was targeting, her PHQ-9 was severe. It was like 25. Her GAD-7 score was also very severe. Her mood disorder score was positive. She said that she's having these mood shifts up and down, but they do happen kind of day to day. And she's got a history of self-harm in the past, so she was kind of giving me a little borderline feel with it too. But she's always had these dark thoughts. And she has this passive SI that she mentioned to me when I saw her back in November, that did get active at times. And she was able to contract for safety, you know, and we had discussed lithium. So when I saw her today, the dark thoughts are still there. They are constant and passive. There's definitely no plan or anything. But she did say, you know, I did have some active thoughts about 2 weeks ago. Her husband took away all the firearms in the house, but one of the thoughts that she's had in the past is going in the garage and turning the car on and doing it that way. So targeting symptoms, I was trying to go by the gene site, but she's also she's a very thin woman. She's got a history of a lot of side effects with meds. So I told her to start the lithium and the Prestige. She's getting labs in the morning. She doesn't have any pregnancy risk. Last time that we checked labs was back last year. Thyroid was fine. Kidney function was fine. But I was targeting the SI. I was targeting the depression and the anxiety. I felt like the Prestige was going to take a while to really kick in. And I was actually wanting the lithium to help with mood stability and the suicidal thoughts. So I did go very low on the dose. I did 150 of the lithium. I told her to take it at bedtime. I'm going to see her on Thursday. I made her make 3 follow-up appointments with me, and I have her booked in for an emergent follow-up on Thursday. And then with the Prestige, I did 25 milligrams. I told her after a week we're going to increase it to 50. So just trying to give me an idea of, you know, usually I don't do 2 meds at once, but I was really worried about the mood shifts and the dark thoughts. And, you know, I gave her the suicide hotline information, told her I would be in contact Thursday morning, to follow up with her. We did have a verbal safety plan today, but just kind of moving forward, I think I kind of jumped the gun on doing both at once, and just kind of thoughts maybe in retrospect, would you have done it differently? Maybe the other ideas.
Yeah, gotcha. So thanks for sharing that. So immediately when I think of this type of picture, that makes me think of a personality disorder. You know, so when someone has the whole DSM-5 as their diagnosis, then it pretty much means that it's you know, when everything's true, nothing's true, if that makes sense. So
Yes.
I'm sure she's struggling with a lot of things. I don't doubt that, but you know, when there's everything that's going on, then this is the type of patient who has every problem, will fail pretty much every medication. I don't think I think what you'll run into is that she'll probably tell you that this won't work either, and she'll tell you that there's X or Y side effect. So I don't think it's really a medication issue. It's more of I don't want to say her issue, but you know, how she responds and how she perceives to medication. Do we know why she stopped care since November?
So she said that her social anxiety was pretty high, and she just doesn't. She went back to the autism spectrum diagnosis about a year ago when she was seeing a psychologist. She was like, yeah, I just don't like to talk about things. She was like, it's not that I didn't like the therapist, you know, I liked you, but I just didn't feel like it was really helpful. So that's why I was starting to get the borderline vibes too.
Yeah.
With her, and then the history of self-harm, and then the threats a lot with her husband over the years. And then she kind of smiled at me and kind of chuckled when I brought up the car, because she said, well, he removed all the firearms. I said, yeah, but I remember that we talked about the car plan that she had back in November. And she kind of laughed. She's like, oh, you remember that? I'm like, yeah, I did remember that. You know, it's an important piece. So I do think I jumped the gun. I think if I went back to it, maybe just starting the Prestige first with close follow-up would have maybe been a better choice.
Yeah, I think that makes sense, but I don't think you're going to run much harm with that low of a dose of lithium anyway. And it makes sense. You were thinking about the SI. So, it's not wrong by any means. In fact, it might help her. I think the most important thing that you can do for her is just develop the relationship and the alliance with her. I don't think I don't think whatever you do is going to make a difference in terms of med-wise. For her, the most important thing is that relationship she has with you, with the provider, that consistency, right? So if you think about BPD from more of a psychodynamic angle, so the fundamental thing is that there's a lack of identity and so they go to other things to get identity. So they go to psychiatric diagnoses, so these give them identity, right? Like the classic, oh yeah, like my ASD is making me do this, or my ADHD is making me do this. Failing everything, now if someone fails everything, then they have all the attention on them, because if they succeed, then they only get seen once every 3 months. But now, if they fail everything, they have to keep going into the doc, they have to keep getting that attention over and over, and then that almost fills that emptiness that they have in their heart. The self-harm, the history, right? So that all feeds into it. The passive SI, but no plan, because then what this does is it gets everyone else overwhelmed. Like, oh my God, there's the SI, there's this, there's that, and so it has them all feeding into it, which of course feeds that need for her. So I'm not blaming the patient, just kind of like helping you understand the thought process. Has she had DBT therapy?
She has not, and
Okay.
She had a really good connection with our in-house therapist that doesn't offer DBT, but I just don't know if she would commit to it. I could certainly bring it up and see if she would be willing to look at it. If I can find a provider, I'm sure that there's providers in the area that she might be willing. But even with the psychologist, I was like, well, what happened with the psychologist? Oh, I didn't feel, I just didn't want to talk anymore about things.
Exactly. This is almost these type of patients. So are you aware of somatic symptom disorder?
Small amount. I think that's kind of what happened with my other borderline, like turning the physical symptoms.
Yeah.
Because of the mental health. Yeah.
Yeah. Basically, it's like the somatic symptom disorder. These are the patients who will come in with like various vague physical complaints, and like nothing helps them, and there's always the type of gut pain or something that's going on. And the way to really treat that is to not buy in too much into them, because the more you buy into it, the more they embellish the symptoms, whether it's a conscious thing or a subconscious thing. So a similar thing happens here. The more that people really buy into what's going on or medicalize her, the more that she kind of goes into that identity, because now this is where she's actually getting that reinforcement, that attention, right? So the strategy to deal with somatic symptom disorder is you just have the brief check-ins, recurrent, making sure that they're safe. So it's like brief, quick visits over time, and just to kind of keep the patient like reassured and going along. So this is almost a patient I wonder would benefit probably more from a holistic kind of treatment, like supplements where you just say, hey, there's no side effects, and you can do things like saffron and magnesium, omegas, like you're just approaching it from that angle, and that might help her with not feeling like there's it's probably safer for her overall. But then you're more like you're doing an intervention that's not going to have much harm, but more importantly, you're having that relationship built, and I think that's what's going to do more for her rather than any kind of medical intervention you do.
Okay, that makes sense. Thank you for that. And yeah, it does. I'm looking at her stuff actually right now. She did schedule a couple follow-ups, so I will focus on that. Building just a strong therapeutic alliance with her and see how she feels. I mean, if she feels like the little sprinkle of the lithium was helpful, I'll keep it.
Right.
But yeah. So just kind of going back in my mind, I was like, I shouldn't have done both. But yeah, I kind of had the targets for it in my mind, but I think I definitely fed into it during the visit today.
No, so. and that's, you have to remember, like, this is what they're good at. Like, they do this so that you feed into it, and it's good that you're recognizing this as well too. And like, this is how, and we have the training to recognize this, but the average person does not. So that's why people who have BPD, they get into these frequent arguments all the time, because they're able to trigger people in such a strong visceral response like that. But then you monitoring your own reactions, like you realizing this, is super helpful.
Thank you.
Yeah. Anything else? Okay. So I think we can just call it for today. So tomorrow I'll be doing a TikTok live podcast with Dr. Robbie again, just talking about financial stuff. So I got that one question from Richard, but we'll definitely have other questions as well too. And other than that, if anything comes up, just feel free to post. And I'll see you soon otherwise.
Thank you.
Have a good night, guys.
Of course. Bye, y'all.
Bye.
Good night.
Okay, so that was pretty much our coaching call for our Psych Academy. So actually, there's something I forgot to do. Yeah, so hopefully that was helpful. So that was our coaching call that we did. So yeah, if you are an NP and you're watching this and you really want to be a part of these calls, you want to be able to ask me questions, get my expertise as a psychiatrist, get expertise or input from other people in the community, you want to learn psychiatry in depth, then definitely look at joining our academy. So I just put a link up there. So yeah, otherwise I think I'm about to go to the gym right now, and we do these every Monday evenings at 8 p.m. Eastern Standard Time. So that's when we have our calls. And so yeah, if you want to join the academy, if you want to feel confident as a provider, if you want help with complex cases, if you want to not have patients disrespect you or your expertise, you want to not feel like you're overwhelmed with patient cases, you want other providers to respect you, and the best way that other providers will respect you is the more competent and the more expert you become, because competence breeds confidence. So if you want all that, the best way to do that is to consider joining our academy. We had over 150 people join in the past 3 or 4 months, so definitely been growing a lot of people are really getting value from it. So either send me a message, I just put up the link, or you can check it in my bio, either or. But otherwise, I shall see you soon. I'll probably do a live stream tomorrow, just more like a whiteboard Q&A stuff. And